is a DVM and a boarded radiologist with more than 20 years of knowledge and experience in clinical veterinary medicine. He was recently on staff at University of Illinois. Dr. O'Brien began his image-related training at the University of Pennsylvania, where he worked with many prestigious veterinarians investigating new and novel imaging protocols and methodology. He adopted a philosophy of test all preconceptions and reject the old and unprovable. Along with Dr. O'Brien's academic career, he became the world's expert in contrast ultrasound imaging, resulting in the landmark manuscript describing the appearance of liver nodules with contrast ultrasound. More recently, Dr. O'Brien pushed the traditional limitations of conventional CT with many novel awake imaging protocols. Dr. O'Brien has taken his open-minded and scientific inquisitive nature into his position as the Director of Imaging for Epica Medical Innovations. So without further ado, I'm going to pass the mic over to Dr. O'Brien and let him take it away. Thanks, guys, for your time.
Yes, hello. We're just it'll take just a second for flipping over. Do you have it over to me, Chrissy?
I'm working on it. I think I may actually be giving myself presenter control. Hang on, Bob. Did that work?
I can't seem to change it to me. I don't know why. Oh, there it is. Me. That should work. Screen 2, and show my screen. How does that look? How does that look, Chrissy? Can you hear me?
Yep. Audio's good and screen is good.
Okay, good. We've overcome the technological, which is obviously causing us great conflagration. So, welcome. Thanks for taking your lunch hour if you're out on the West Coast. Thanks for taking your lunch hour if you're East Coast and you're either taking a late lunch or you're done for the day or somehow you broke free, and I really appreciate it. So again, I'm most recently from the University of Illinois. The topic today, the coughing dog with a murmur, was actually the title of a master's project that was just recently completed by one of my residents who's since finished his residency. And what we're trying to do is put the results of that research together with the clinical correlation of kind of a more global look at coughing dogs just in general. So we're going to be adding a little bit of film reading, we're going to be doing a little bit of review of the recent literature, and then discuss the results of the research and try to integrate that into your daily practice. So without further ado, if I hit the right button, we'll move on. So coughing dogs obviously can have many causes. In cats, it's actually quite limited. I'd say probably somewhere between 80 and 90% of cats that are coughing probably have lower airway disease, and that's sort of it. And so that, of course, doesn't account for everything, but it's getting close to at least one standard deviation of the mean, which is pretty high for one particular differential to cover that high a percent of the total prevalence of a particular clinical sign. In dogs, it's quite challenging, and obviously that's the reason to take radiographs even more so, is that you can't play odds with what a dog might have when it's coughing. So in the example that I'm showing on the slide, and let me go to the next slide, which will kind of point out some of the features of it. We will be covering film reading and more specifically thoracic film reading in our next webinar, so I'll invite you to join us then when we kind of do a more global view of chest radiography, thoracic radiography, and lung patterns specifically. But this would be a good launch off for that lecture also, because this dog has thickened and more opaque bronchi in pretty much all the lung fields, certainly everywhere that I'm pointing to with both my pointer and those red arrows. I think of this as a pretty unusual radiographic manifestation. It's not an unusual disease because chronic bronchitis is common in many species, most species arguably. But in dogs, it just seems uncommon that we see this stark thickening and opacity change to the bronchi. And we have lots of chronic bronchitis, and more often than not, they're pretty normal looking chest films. So this would be, I think, an exception. Other diseases we see just as commonly, or that are maybe easier or harder to diagnose depending on what your particular skill and experiences are. In the images provided, we can see increased opacity in the right cranial lung region. There's a very well-defined lobar sign on the caudal margin of the VD radiograph, as well as on the dorsal border of the lateral radiograph. And on the lateral radiograph, you can see the bronchus heading down into the disease, and it actually gets wider as it's heading towards the disease, towards the periphery, as evidenced of bronchiectasis. And bronchiectasis carries a certain prognosis with it. If everything else being equal, bronchiectasis is very commonly associated with squamous transformation of the ciliated mucosa. So just to see a dilated bronchus is to sort of assume that we have impairment of the ciliated epithelium and the mucociliary apparatus that would clear bacteria and other debris out of the lungs. And so it leaves lungs, or lung lobes at least, at reasonably high risk for recurrent pneumonias. So it's a negative prognostic indicator, everything else being equal. This particular dog didn't respond to antibiotics, and we went on to kind of the next generation of testing, which was to do a fine needle aspirate, and this dog had lymphoma. And lymphoma is always on our differential, seemingly in every organ for everything, everywhere, especially in cats. But it needs to be on your list of differentials for the geriatric patient, of course, most places. But in the lungs, it can either be a diffuse unstructured interstitial pattern, or it can be this alveolar pattern. So it is on our list for an alveolar pattern that doesn't respond as it should to an appropriate course and type of antibiotic therapy. For those of you in the West Coast, especially I guess in the southern part of California, you may recognize this particular lesion. There's increased opacity in the perihilar region, but it's quite discrete. You can see the borders quite nicely, outlined by the red arrows now. For the classic 2-year-old Labrador, either in the Midwestern United States or Southwestern United States, fungal raises a very high degree of prevalence for this sort of appearance, because many of the fungal etiologies go through the draining pulmonary lymph nodes, in this case the tracheal bronchial lymph nodes, and that may be the end of the disease as far as its distribution within the body. Of course, each fungus does something unique and goes to different parts of the body, but certainly coccidiomycosis and blasto, this is pretty common distribution sites just because most of the spores are inhaled, and so this is the draining lymph node of the lungs. The example I'm showing you is the middle tracheal bronchial lymph node, and the middle tracheal bronchial lymph node lives caudal to the tracheal bifurcation. And this circle is the tracheal bifurcation, so this mass effect that we're seeing caudal to it is appropriate, and it would be on midline on the ventral dorsal radiograph if we had that. There are 2 other large tracheobronchial lymph nodes that are commonly affected, and for the cranial lobar bronchus that they're affiliated with. So there's a left tracheobronchial and a right tracheobronchial, and they live respectively cranial to the left cranial and cranial to the right cranial lobar bronchi. And so on the VD radiograph, they're cranial to the cranials, and the middle is caudal to the caudals, is how I used to teach it with the students. Now, if this was a geriatric patient, or it wasn't in those areas of predisposition for fungal, then we'd be going down the neoplastic differential list, with lymphoma being probably number 1, but just moving on through some of the other round cell tumors and some of the atypical diseases, including myeloma, mast cell disease, or some of the histiocytic diseases would certainly be reasonable differentials for this dog. And the mass in this area will certainly make a dog cough, and that's usually why they present to us. Other lesions that can make a dog cough, this dog obviously has pretty wide distribution of disease, multifocal lesions. We could almost say the words everywhere. It's certainly in all lobes. But if we kind of look discretely, we start to see certain of these places are rounding up. And this pattern is common with metastatic hemangiosarcoma. The nodules are, of course, the actual tumor distribution, but the nodules bleed because of the vascular basis to the tumor. And so this coalescing of nodules and indistinct borders and even to an alveolar pattern is a common manifestation of metastatic hemangio. And it's sometimes hard to see the nodules through the haze of the hemorrhage, the pulmonary hemorrhage that's going on concurrently. And then sort of finally is kind of a mass sort of list of things that make you cough. In this case, it's cranial mediastinal mass, as evidenced on the ventral dorsal view by widening of the cranial mediastinum and rightward deviation of the trachea, dorsal deviation of the trachea on the lateral view, and then even just for good measure, another nodule or another mass lesion as a nodule in the fourth intercostal space. So then we'd run through the list of things that either drain into the cranial mediastinal lymph node. That could be anything in the head and neck region, neoplastic or reactive, although it's huge, so it's probably malignant, and or tumors of the cranial mediastinum themselves, thymoma versus thymic lymphoma or mediastinal lymph node lymphoma. So getting more into the airways, and this is really going to be a discussion today of airway disease. This is the same patient, and sort of it's one of those, believe it or not, it's the same sort of patient sort of discussions. And in this case, the dog is being radiographed during complete inspiration. And typically what happens with the intrathoracic airways during inspiration is that they will be opened up by the intrathoracic pressure and traction. All potentially collapsing airways within the chest will become more open during inspiration. And it's usually the cervical or the thoracic inlet parts of the trachea that will collapse. And you can see in this particular dog, there's increased opacity at the level of the thoracic inlet, but no really collapse. Excuse me, I've got to cough myself. Excuse me, it's the power of suggestion, apparently. On expiration in the same patient, you can see there's a total change in the diameter of the airways and almost invisible because of the complete collapse at the level of thoracic inlet and the cranial interthoracic trachea. Excuse me. And maybe one of the learning points of this slide is to heartily recommend to you taking a purposeful expiratory phase, at least one lateral radiograph, if you think the dog has dynamic disease. So if it's of the right signalment, so we're talking miniature dogs, kind of dystrophic dogs, in the middle-aged to older category, with the appropriate kind of cough, breathing cough, or the tracheal sensitivity cough, then taking a purposeful expiratory phase and comparing that with your inspiration, if there's any substantial change in diameter between those two images, or of course if it completely collapses or very narrow, then it certainly is an easy way to confirm the diagnosis. And in fact, taking the inspiratory phase radiograph is about the lowest chance of seeing that collapse, if the collapse is going to occur in the chest, of any view you could possibly make up. So the irony is we take inspiration to see lung changes very well, but we don't see the dynamic airway changes in the chest at all unless we go out of our way to think about taking an expiratory phase. And this was actually done accidentally, of course, not purposefully. But at the University of Illinois, we used to take quite commonly 3-view, 4-view, or even 5-view chest radiographs, which included things like the lateral neck for a coughing dog or the expiratory phase. So our routine was 3 views, right and left lateral and VD. The 4th view might have been the lateral neck as appropriate for laryngeal disease, pharyngeal disease, and then the 5th view was this purposeful expiratory phase lateral radiograph. And it didn't matter right or left. It doesn't seem to matter to which one. Okay, so heading off into the research, and therefore the purpose of the talk, there are a couple kind of truisms that I'll throw out to you, and you'll have to decide if you were taught this or not. And so that's the question mark part of it. I was taught that dogs cough when they are in left-sided congestive heart failure. In other words, pulmonary edema makes you cough. And that's a truism clearly of human medicine, because if you Google nocturnal cough, if you just go into a web browser and Google nocturnal cough, in their list of no matter where you go, you will see left-sided congestive heart failure towards the top, if not at the very top of the list in humans as the cause of a nocturnal cough, much less just a regular cough, but certainly nocturnal especially. And I think we've adopted that without much testing in veterinary medicine, and I guess I'll let you again make your mind at the conclusion of the talk, just whether you think that's true or just a truism. And the other thing, maybe a component of that same phenomena, is that a big left atrium makes you cough. And it does so by the dorsal deviation and the compression of the bronchi or the trachea at the level of the heart itself. And so these are two things that we kind of wanted to test, as well as make use of the recent literature. So in the recent literature, what can we learn from that has already been published as it relates to, does an enlarged left atrium compress the left lobar bronchus or the left principal bronchus? And for that, we went to the Journal of Veterinary Internal Medicine in 2012 with a study out of UC Davis, University of California, Davis, which presumably many of you on the West Coast are graduates thereof. Dr. Johnson was actually a classmate of mine at Ohio State University, and Dr. Pollard is a colleague in the radiology department. And they did a prospective study that looked at 16 dogs. This was a study that included bronchoscopic evaluation and echocardiographic evaluation. So they compared the size of the left atrium with the patency and diameter of the large airways. And they concluded that they failed to identify, so there was no association between left atrial size and airway collapse in dogs with mitral valve disease, which I think is really interesting because, it's again the truism that we've been taught. So this was kind of landmark stuff. But they did suggest, the results did suggest that airway inflammation is common in dogs with airway collapse. And I don't think that's any big surprise. In any dog with collapsing trachea, for example, where you're coughing and you're constantly irritating that mucosa because the mucosa is meeting the mucosa in a big clapping movement, of course is going to cause irritation. Now, quite specific to this comment is the word inflammation. It doesn't say the word infection. So this does not imply that these dogs have bronchitis or tracheitis. It implies they merely have irritation. It may be sterile inflammation. It doesn't have to be septic inflammation. So to me, it's just a mechanical effect versus a cause of the airway collapse, where some people say the phrase, well, if you have chronic bronchitis, that leads to coughs, which lead to tracheal collapse or bronchial collapse. There's really no evidence in this paper that that was in fact the case. It's more likely it was the reverse. So what does the literature have to teach us as far as what causes a cough? And for that, I kind of choose the 2013 paper, which was a very nice, very large-scale retrospective study involving 206 client-owned dogs. Dr. Borgarelli is probably the world's leader in the research on mitral valve disease. My colleagues, Dr. Biller and Dr. Lamb, were at Kansas State when this study was being performed. Again, it's a retrospective study, so it doesn't have quite the quality of a prospective study, and there's no control group. Then again, the last study didn't have a control group either. That's how things sometimes go in clinical studies. And so they looked at a very large number of factors, mostly based on the echo and the thoracic radiograph. And what they concluded was congestive heart failure is not a significant factor that's associated with coughing. And so that's really kind of the take-home message here, is that within the confines of this study, however, they determined congestive heart failure, which was presumably pulmonary edema, presumably the presence of pulmonary edema associated with substantial cardiac enlargement, I assume they put it together like that, was not associated with coughing. In that instead, an abnormal radiographic airway pattern, presumably, again, what we imply from that is a bronchial pattern, And left atrial enlargement was associated with coughing. Now, they didn't talk about what the effect that the left atrium enlargement was having that was causing the cough, but presumably it was the mechanical effect discussed previously of dorsal deviation compression, which had arguably already been refuted 1 year earlier based on the University of California Davis project. So clearly these two teams were not discussing their results with each other before the two published their results, because they tend to be at odds with each other. So now you have to decide if you're going to believe, or which parts of this you're going to believe. So, one, heart failure does not cause a cough, or is not strongly associated with coughing dogs. And again, an enlarged left atrium does not cause airway collapse, but it somehow does cause a cough. And so that's a little tough. I mean, you can't say, well, based on these two papers, we have a very clear understanding of what causes dog coughing, at least in my opinion. So they're kind of at odds with each other, and they're a little bit confusing. So with that as the background, we began the project of what we call the Coughing Dog Project. It's a comparative imaging study of coughing dogs with a murmur. We did not do any bronchoscopy. We did not do anything that involved general anesthesia. These dogs came in, they were imaged usually within about an hour, and then they were sent back to the referring veterinarians. These are all referrals for the research project, exclusively for imaging. They came in, they were imaged, and then they were headed back. They were all accumulated from the local area within a few hundred miles of the University of Illinois in central Illinois. And limited financially to about 40 dogs, and these are the 40 affected dogs, 40 coughing dogs. And we used 20 normal dogs as our control group. And these other 20 dogs were dogs that were not coughing. They were imaged in CT for other reasons. So these would be things like MET check for primary osteosarcoma or masses in the abdomen, or usually it was a MET check that the study was being performed on. So that were our negative controls, our unaffected non-coughing controls. To be in the affected group, for us to recruit these, they had to be currently coughing. They could be treated for their cough currently, but they had to still be coughing. So in other words, they're kind of failing their therapy. And they had to have a murmur, at least grade 3 as judged by us. If it came in and it was barely detectable, then it really wasn't worth running the study, because there's so many other dogs running around with grade 1s or 2 murmurs. So it had to be a grade 3 or higher murmur. Now, you may guess, I'll let you know here, but I'll let you kind of think about it for just a second. You know, who do you think we recruited into this project? You know, what dogs, breed of dogs, age of dogs were coming into this project? In other words, what do you see in practice, and what would you have referred as a caseload to us? So, of course, the answer to that question was mostly middle-aged to geriatric patients in the miniature breeds. And so the Chihuahuas, the miniature poodles, the Shih Tzus, the Lhasas, some chondrodystrophics, a few French Bulldogs, Pugs, Bostons, that kind of thing. We only, I think, had 2 dogs that weighed more than 20 kilograms. So the vast majority, 38 dogs, were less than 20 kilograms. In fact, the vast majority of those were even substantially smaller than that, except that many of them were obese, and so they had, their weight wasn't necessarily their lean body weight. So it's a highly predisposed group with this concurrent murmur and coughing. This is not what we see in dogs with DCM. Labradors that get DCM are not going around coughing. Boxers with arrhythmogenic right ventricular cardiomyopathy are not coughing commonly, and if they cough, they're usually easily treatable, and they're not going to be a problem to you out in general practice. They may be passing out, they may have syncope episodes, they may have exercise intolerance, or they may not be eating their dinner, but they're not coughing commonly. At least that's my assumption, because we didn't get many of these cases at all. And I'm going to give you also the punchline. We're only halfway through the seminar, but here's kind of the answer to the question in our opinion. So I'm going to do some CT anatomy with you, and on the normal side, on the side to the right, you can see the spine at the top, which is white in CT, and below that the esophagus, and below that the tracheal bifurcation, and to your right is the left side, and to your left is the right side of the dog. So this represents the left principal bronchus, and this represents the left caudal lobar bronchus, and of course on the right side, similarly the right principal and the right caudal lobar bronchus. And this is what it should look like. So when you leave the tracheal bifurcation, the principals are quite dilated, they should be quite dilated, and then there's a general tapering as you go further out. The anatomy that's important to understand at the site is easier to talk about on the abnormal side. On the abnormal side, of course, it's the same anatomy on the normal side, but it's just easier to see. So if we go on the slide on the left, which is one of our patients in the coughing dog, you can see that ventrally, the left atrium is the structure ventral to the tracheal bifurcation at the level of the left principal and the left caudal lobar, and the same structures on the right. So the left atrium forms at the floor of those structures. The structures dorsal to each one of these is what's interesting. Dorsal to the left principal is the aorta. And dorsal to the left caudal lobar bronchus is the left caudal lobar pulmonary artery. So that's what this circle represents, the pulmonary artery going to the left caudal lobe. And similar structures are on the right side, but obviously there's no aorta on that side. There is still the pulmonary artery on the right side. But you can see there's quite a difference on the right side without vascular structures to the left side where we have the aorta and we have the pulmonary artery on the left. And part of the study, part of the results of the study indicate that this predisposes these dogs to collapse. And so there's the rock and hard place, that these airways are stuck between the rock, and it's your choice who you want to be the rock and who you want to be the hard place. We'll make the hard place the left atrium for sake of argument, and the rock is going to be this immobile 120 millimeters of mercury, high pressure, very firm surface, which is both the aorta and then the 25 millimeters of mercury pulmonary artery. So these are immobile and high pressure, very firm structures up against the heart base, the left atrium. And if there is a propensity to collapse, in our opinion, they will collapse, being squished, as it was, between those two immovable, firm objects, shall we say. And that's not very scientific, but let's go through what we did and how we measured these particular features. So again, we measured the area, the diameter of the aorta at the level of the left principal. We measured the diameter of the pulmonary artery at the level of the left caudal. So we measured the luminal dimension of each of the airways. We measured the diameter of each of the vessels at that same level. And we used this as the aorta as the built-in standard because the absolute diameter theoretically was not going to be as important as a ratio would be along the lines of measuring the left atrium. So the absolute measurement of the left atrium in a dog is totally dependent on the breed and the size of the dog. In cats, we use a single measurement because they're not as variable anatomically, but in dogs, theoretically not knowing that we were going to have a whole spectrum of sizes, we tried to normalize the data compared to an internal standard. And since the cardiologists were already doing it, it seemed to make sense that we could use the diameter of the aorta as our built-in standard to normalize the data to the size of the patient that we were looking at. And so, and this is the kind of the, remember we talked about the rock and the hard place, so here's our hard place, the left atrium. If I remove that superimposition so we can see it again on CT, it's pretty easy to see the left atrium and actually to measure the left atrium. You can see fat surrounding the aorta, so this darker shade of gray represents pericardial fat, or fat in the heart itself, surrounding the aorta, and we see this in both cats and dogs. So you can measure, you can see the aorta as a distinct structure here. So this would be the aortic valve area, and then it goes around, and this is the descending intrathoracic aorta. Quite a difference in diameter. And dorsal to the aorta is the left atrium, which, of course, as you go over to the left, forms the left auricle. And that's the little pointy object over here. So again, I've drawn it for you so you can kind of see the superimposition on the diagram. The other issue that we wanted to address was there are people out there who believe, based on their experience, which is a good thing to believe in, that because of this predisposition of the Shih Tzus and Lhasas and some of the chondrodystrophics, that perhaps this was not an issue of size of the left atrium, that maybe was more of a problem of chest conformation. So again, we're not seeing this disease in the Dobies and the German Shepherds with deep chests. We're seeing it in the barrel-chested, short-chested breeds like the terriers, etc. So to test for that effect, we measured the height of the heart, so it's the measurement from the apex of the heart up to the top of the base of the heart, compared to the height of the chest from the dorsal aspect of the sternum to the ventral aspect of the vertebral body at the level of the tracheal bifurcation. And it turns out this did not have a statistical relationship, that there was no affiliation, no association between the proportion of the chest occupied by the heart versus the size of the the size of the principal bronchus and or its association with the group. So in other words, we compared the control group versus the experimental group with the height of the chest, coughing, not coughing, and there was no difference. Excuse me. So I want to go through 3 cases with you if I can. And there are some learning points that I want you to take home, because although this is a CT project, and we will talk about this being CT as the gold standard for this particular disease, there are a couple things you can take home that I think will be very useful in general practice as you look at your chest radiographs for this particular disease. So this is a 10-year-old female spayed Chihuahua, cough and a murmur. The arrows are pointing to the two principal bronchi on the lateral radiograph. So the trachea is undulating. This is the tracheal bifurcation, immediately caudal to the tracheal bifurcation of the two principal bronchi, the left and the right. The left always goes up. Of the two, when they split, because it's going up and over the left atrium, regardless of whether it's a normal left atrium or an abnormal left atrium, the left is almost always dorsal to the right. So we see these two bronchi. There's one dorsally and one ventrally. This is the left, and we don't know it's the left because we see the left on the lateral radiograph. We know it's the left because it's dorsal. And you can, I think you can hopefully see on your image that the diameter of the left is considerably narrower, probably 1/3 the diameter of what we're seeing on the right. And that's really common, that the left is predisposed. It's not that the right does not collapse. It just doesn't collapse to the same level or the same prevalence as we see with the left principle. And I'll discuss the results of the experiment as we continue through the talk. This dog also has thickened bronchi. We can see it summated upon the ribs and the caudal lung fields, bronchus, bronchus, bronchus. So, and possibly a big left atrium. So what I'd like you to look at in each of these cases is, one, is the heart enlarged? You know, you have to make a decision in your practice whether the heart's enlarged or not. These guys all have a murmur, but that's not the question. The question is the heart enlarged, and is the left atrium enlarged? And then you have to decide in this coughing dog, with the lung pattern that you see, does the dog have concurrent pulmonary edema? In other words, based on what you see with these initial radiographs that I'm showing you, would you have put the dog on Lasix and Allopril? And would you have, you know, in your clinical setting, would you feel validated putting that dog on heart medication? And then we'll show you the answer and you either get it right or wrong, kind of certain thing. There's also collapse of the right middle lung lobe on the ventral dorsal radiograph. On echo, there was no left atrial enlargement. The heart was essentially normal. He had mitral valve insufficiency, but it was totally compensated. His LA to AO ratio was only 1.2. Normal goes up to 1.5 or 1.6. So it was well within normal range. And this is his CT. And the CT is always the ringer in almost all these cases, with a few exceptions. And in the caudal lung field, we can see thickened bronchi. This correlated quite nicely with the radiographs. It had an interstitial component also, presumably pulmonary fibrosis. And at the level of the tracheal bifurcation, there's complete collapse. I'll go over to that one. So there's complete collapse of the left principal and almost complete collapse of the left caudal lobar bronchus. So again, we're looking here ventral to aorta, And then the next couple slices back, we had to kind of go back and forth a few slices to get both of these structures. You can see the pulmonary artery. So there's no airway to be seen. So complete collapse of the left-sided structures and patency of the right. A little bit of probable pneumonia here. There's an alveolar pattern adjacent to this bronchus heading down into the ventral portion of the right caudal lung, as well as in the right middle, probably in this particular region. So lower airway disease, pneumonia, and collapsing airways, specifically the left principal and left caudal lobar bronchus. Essentially not seen on the radiograph. Second case, a 13-year-old male castrated small mixed breed dog named Piper. Again, we're looking at fairly confounding radiographs. These are tough, almost always tough radiographs to read. Quite often these little guys are obese. They don't have to be, but quite often they're obese. They're aerophagic, so they're swallowing air, and that's causing a mass effect in their abdomen. Quite often they have enlargement of the liver with steroidal hepatopathy, very common in that segment also. And that leaves the lungs quite opaque. The heart will fill up the chest, and then we have to decide, does it merely subjectively look big, or is it truly big? I tend to use the vertebral heart scale. On these particular cases, I find it more valuable than my subjective interpretation, but we'll leave that for another day and another lecture. So we can see the principal bronchi, they're each other, and then there's an abrupt end to the principal bronchus as far as its air-filled component, and we kind of get an increased opacity in one of the intercostal spaces. On the ventral dorsal view, we can follow the trachea down to the tracheal bifurcation, which is a little bit displaced off to the right side. And we can follow the nice air-filled tube that is the right principal bronchus, where it branches in the middle, and the caudal lobar bronchus. But on the left side, there's complete cessation of that air-filled column as it goes under the ribs, and we don't see it as it comes back out. There is really, we know where the bronchus is based on its association with the vasculature, but we don't see air within the lumen. Similarly, we see air bronchograms associated with that caudal lobar bronchus, and that's in a place where we'd be very concerned about pulmonary edema because the right side is often a predisposed location compared to the left side. So the arrows to point to both of those principal bronchi. What did we see on the CT? Well, it turns out there's essentially no mitral valve disease. The dog had severe pulmonary hypertension, 80 millimeters of mercury based on its tricuspid insufficiency. We had no really hint of that at all on the films, and radiographs are just horrendous to try to guess who might be pulmonary hypertension based on this study and many other studies. We can see thickened bronchi out in the periphery, as well as the interstitial component of a COPD type of lung pattern, and complete collapse of the left principal and the left caudal lobar bronchus, and patency of the right by comparison. So again, very severely affected large airways, but also lower airway in interstitial disease. And if we take this data set, which is the CT, and do a virtual endoscopic evaluation, this is what we see kind of looking from the inside out. This is the right principal bronchus with its patency and open lumen. This is the carina, which is right at the level of the tracheal bifurcation. It's the ridge of tissue that forms at the bifurcation. And this is the left principal bronchus completely collapsed in an awake dog, breathing passively, mildly sedated on butorphanol. And so this is what basically this dog is walking around with every day. These are, someone asked me in the last webinar, you know, did you account for the cardiac phase? Well, not only did we not account for the cardiac phase, which we call gating, but we did not account for the phase of respiration. This data set took us anywhere from 10 to 15 seconds to accumulate this data set, which is the CT exam. And by that, during that time, during the 10 to 15 seconds, we know that the dog probably went through 2 or 3 respiratory cycles, and so we have no idea what phase this is. I call it phase indeterminate CT. And this is our last case. So this is Daisy. Daisy is a 7-year-old female spayed Shih Tzu, as you can see on the slide. Trachea comes down, tracheal bifurcation. Right principal bronchus, nice and wide, almost the same width as the tracheal bifurcation. Left, she's just nobody home, just almost total collapse. Big heart, tall, certainly a tall heart. I'd still measure it to be sure, but a large left atrium on the ventral dorsal view. So some of this opacity that we're looking at would most likely represent the left atrium. The question is, does any of this opacity represent pulmonary edema? In my opinion, the lateral view is not as valuable for that. We certainly have a hint of increased opacity, but I go over to the VD radiograph, and I use this one much more than the lateral because the lateral is looking all the way across the chest. The VD kind of isolates this part of the lung, and we know this is where we're going to see the edema in the perihilar space. And so I can see the border of the heart really well. I can see the border of the left atrium very well. That just wouldn't be the case. I would not see these pulmonary vessels so clearly if there was pulmonary edema superimposed. So I think it's very unlikely, even though I know the answer to this case, that there is pulmonary edema in this particular dog. And as you come down the trachea, similar to what we did, and I suggest this as a technique, just follow the trachea down till it bifurcates. In this case, we can see the right, nice air-filled space. In the left, it just stops right about here. I just don't know exactly where the left principal is going in the left caudal lobar. And presumably, again, it's due to collapse. And so let's test that again based on one, well, what does the echo look like? The echo shows quite nicely dilation of the left ventricle, probably thinning of the wall, or at least disproportionately thin wall, thickening of the mitral valve leaflet with prolapse, enlargement of the left atrium on this right peristernal view. And in the left apical view, large regurgitant jet, so a large volume fills the entire left atrium, and it goes all the way and hits the back wall, dorsal wall of the left atrium. And what does it look like on the CT? On the CT, all of the airways are really compressed. We see no large airways at all. We see some small airways with thickening out in the periphery, but below ventral to the aorta, nobody's home. Ventral to the pulmonary artery, very, very thin diameter to the left caudal lobar bronchus, and the lungs are essentially clean. So nice, normal looking, lucent lungs. So that's not what that dog's problem was. On the other hand, if you'd given this dog Lasix and it had responded, and what I mean by response is that if the coughing was either resolved or at least was less frequent, then how justifiable, how valid is that cause and effect? So again, the scenario is we have the signalman of dog, they are coughing, they have a murmur, and you're going to test that theory that they have left-sided congestive heart failure by giving them Lasix, and that we expect that if it's not heart failure, they wouldn't respond, and that if they do have pulmonary edema, it's due to it'll be resolved by the Lasix, and that's a test for left-sided congestive heart failure. I sort of reject that premise, and so this is my basis for saying that. Yes, furosemide is a loop diuretic, and it does diurese. But recent studies have also shown the drug possesses anti-inflammatory properties and has a molecular structure similar to that of glucocorticoids. And so just kind of think about it. If I have a coughing dog that does not have edema and I give it furosemide, there's a good likelihood he'll stop coughing, or because you're giving him a non-specific anti-inflammatory. And it doesn't test whether he had edema. It merely is a non-specific anti-inflammatory to a dog that has an inflammatory condition. It may also have edema. I'm not saying it doesn't have edema. It's just it doesn't test specifically for edema. And the resolution of the cough, as we've already pointed out, cough is not a very common thing to see with edema. And so the resolution of the cough, based on the empirical administration of furosemide, is neither a test for the cough nor a test for edema. And so I think the empirical furosemide is extremely valuable as a test for edema, but not in terms of the cough versus no cough. It's either going to be, it improves the clinical signs, the respiratory rate goes down, the dog now has a good appetite, it's bright and alert, the pulses are much stronger, syncope goes away, and or the radiographic manifestation of improvement. So the lungs look like they had edema. I take films 24 hours later, and yes, they're better. That's how we recommend you use furosemide, not as it relates to the cough component. And you say, well, why are you making a deal about that? Because I've seen cases, because we have seen cases where people have tested the furosemide. And in fact, in the case population we had, of the 40 dogs, 20 of the dogs-ish, 20 of the dogs were on pretty high doses of furosemide and enalapril when they came to us, and they were still coughing. And a lot of people adjust the dose of Lasix based on the response to the cough, not based on the radiographic manifestation or anything else, just based on the cough itself. So this is actually quite common. It may not be common in your part of the world, but it was common in our part of the world. And it's actually one of the bases for the research to be performed in the first place. So again, as a take-home message, we strongly urge you to evaluate the area of the principal bronchi. Look at where they are, look at their dimensions, look at their diameter. Try not to be biased by the murmur component of it. Almost kind of throw away the fact that the dog has the murmur and just evaluate the airways as airways in the dogs that have the right signalment. And we use both the lateral view, because we know they're going to be disparate. The dorsal one is going to be the left and the ventral one the right, and the ventral dorsal view, where we can see the airway. It's not quite as clear as it is in the lateral view, but we can still see the airway in the right and the lack, in this case, of an airway on the dog's left. And you can window and level with digital radiography. You can kind of window and level it, change the contrast so you can make it more or less obvious. So specifically, what were the results of the project? What was causing the dog's coughs in those 40 cases? The left, by far, the only statistically significant factor of all the research, of everything that we measured, the only correlation that had a strong association that separated the control group from the coughing group was the diameter of the left principal bronchus. So left principal bronchial collapse was by far the most common lesion we saw amongst the 40 dogs in that group. The others, there were some dogs that had pulmonary hypertension that was detected on echocardiography, and it's really the only test you can use. Some of the dogs did have pulmonary edema at the time of presentation, and again, these weren't mutually exclusive. Some of them were occurring in the same dogs, 2 or 3 diseases. And as I showed in one of the dogs, a small percent had pneumonia, usually associated with lower airway disease. Looking at our radiographs and thinking about radiography throughout my whole career, how would I interpret the ability of radiographs to detect those various diseases? Well, I'd have to say it doesn't do a very good job with large airway collapse. You can utilize those tools that we've given you, but it's not being taught broadly throughout the curriculum, because I wasn't teaching it, and I don't know anybody else who teaches people to look at the principal bronchus in multiple views. Hypertension. Radiographs are essentially useless for that particular diagnosis because you need exclusively to know the tricuspid jet, and that's the sole entity of echocardiography. And then even pulmonary edema. I'm a little shaky now. I'm a lot more hesitant than I was before this project, and how strongly do I believe the presence or absence of pulmonary edema? And I think seeing the response to Lasix is often quite valuable in that, if you think it's edema and you give it Lasix and it doesn't change and you gave an appropriate dose, then it probably didn't have edema, because it's the only form of edema in the body that is as labile that would respond within 12 to 24 hours. No other form of edema is going to respond to a dose of Lasix. It may make you feel good to give Lasix for other forms of edema, but the only one that responds is the one that's caused by changes in hydrostatic pressure, which is pulmonary edema due to left-sided congestive heart failure. So just to close it all up then, what is this disease we're even talking about? Some people call it tracheal collapse, but again, that's a misnomer because we're seeing it in the bronchi much more commonly than we are in the trachea. Essentially, none of the dogs in the project had a tracheal collapse, and that was an incidental finding, but it's nowhere near as common as bronchial collapse. And bronchial collapse is probably occurring in 5 to 10 dogs for every single dog that has tracheal collapse. And it's the same disease. It's chondromalacia, which is degeneration of the cartilage within the supportive structure that is the large airway. So any airway that has cartilage can have degeneration of that cartilage, and for sake of argument, we're just calling it chondromalacia. It's extremely common in these small breed geriatric patients, and there's no doubt that it causes cough. Any total collapse of an airway will make you cough. And again, seen in the miniatures, chondrodystrophic, middle-aged geriatric patients, probably at least previously underappreciated on radiographs. I see it every day in my teleradiology business. This is extremely common stuff because you see these patients too. And it's not detectable on echo. Echo is not going to give you the answer for this. It detects cardiac disease. It does not detect cardiac failure. So how can you detect it? If you don't see it on radiographs, who can detect it? Well, CT is available, and usually this is an awake CT. If it's done under general anesthesia and positive pressure ventilation, then you'll actually blow up the bronchus. You'll dilate them beyond what they normally would do because you're putting positive pressure within the lumen of a very soft structure like a balloon. It'll inflate. So it has to be an awake, non-intubated CT examination, or it can be done fluoroscopically. If you have fluoro available to you, and since you're a Vimigo client, then we have the fluoro built into the system, and you can actually watch the dog cough and watch the airways collapse, or do endoscopy. And again, endoscopies under general anesthesia, potentially or with or without positive pressure ventilation, and there's really no good study that's looked at the diameter of the airways endoscopically versus what they look like awake. The internists don't seem to have much interest in that, and they believe themselves, and there's every right to believe they should. They think that endoscopy is the gold standard for looking at the luminal dimension of airways. And I would argue CT, they would argue endoscopy, we're friends, and so that we can all argue for our own particular imaging modality. What's the treatment? What we really want for treatment is a stent. We want to be able to put something into this lumen of this bronchus and open it back up. There are no stents currently for bronchial collapse, and that's really an unfortunate thing. I think that will be one of the great improvements of airway medicine in the future. We'll be trying to do some 3D printing of structures that would fit into these airways that the dog wouldn't cough back out. But all we really now have is anti-inflammatories. We have cough suppressants. We have antibiotics if there's a concurrent chronic bronchitis, and then you get to decide whether you want to go down the path of corticosteroids, which are obviously potent anti-inflammatory medications, but they also at higher doses cause degeneration and breakdown of connective tissue, which doesn't sound like it's such a great thing to do in a disease that's defined as a breakdown of supportive structures. So would you worsen the collapse? Who knows? And again, some dogs, it's a life or death situation. A coughing dog that keeps its owner awake at night is at high risk for being euthanized, in my opinion, because when they say the dog is suffering, it's not so much the dog is suffering as much as they are suffering because, of course, they're being kept awake by this chronic nagging cough. And so with that, I want to thank you very much for attending the webinar. This is my world up in Maine, where I currently reside, and I'd be very, very happy to take any questions. Thank you very much for attending.
Thank you, Dr. O'Brien. I have one question that came through so far from Dr. Kenneth Fisher, and he's asking if furosemide also helps dogs with edema by contracting the heart volumetrically, thereby reducing pressure on the bronchus.
Ooh, okay, so then we're kind of doing the roundabout. What I maybe didn't make clear, so here you go. There was no correlation with the size of the left atrium in the coughing group. So in other words, all these dogs were coughing, and we were comparing the size of the left atrium in the coughing group, and we had it all stratified. The reason there's 40 is we had 10 in each size group of the left atrium. It wasn't the murmur that defined them, it was the size of the left atrium. And so there was no difference in the diameter of the left principal bronchus in the severe group versus the normal group. So there was no correlation with the size of the left atrium as it dealt with the diameter of the left principal bronchus. So arguably these guys, it could have been a group of any middle-aged dogs and we probably would have come up with the same result. The murmur, and therefore the size of the left atrium in this statistical analysis did not play out as a factor determining the diameter of the left principal bronchus. And maybe I didn't make that point clear. So Lasix making some change to a size of a vessel or to anything, arguably, wouldn't affect the diameter of the left principal bronchus. Now, that's a very broad blanket statement, and so I refute that because I don't believe anybody who makes broad blanket statement, and I also don't believe statistics all the time. In other words, do I really firmly believe that the left atrium has no effect? That's a different question than being statistically associated with it. Now I'm going to change the argument. Does it have no effect? No, I think it definitely has an effect because the whole basis of this rock and hard place is that the left atrium forms part of that impingement. And you would think that the left atrium is twice as big as a normal one, that's going to have more likely to have collapse or decreased size. And so for the 40 dogs that we did, there was no association with size of the left atrium. In other words, we regressed that data. We said, okay, if we look at all the numbers of the left atrium and we run that and regress that against the diameter, is there an inverse relationship that would show that as your left atrium gets bigger, your left principal bronchus gets smaller? Absolutely not. There was no relation to that at all. So I think the effect of Lasix on cough is strictly its anti-inflammatory effect. But that's a personal opinion. We did no science that proved that one way or the other. That's a really good question. It's an interesting question. It's also a really difficult question to isolate because you can't isolate the anti-inflammatory effect from the diuretic effect, from the stroke volume effect, load effects that Lasix actually has. So unfortunately, you can't get at that data unless you can find a different diuretic that doesn't have the anti-inflammatory effect. So you may be able to test it with something like, I suppose, spironolactone. If it doesn't have anti-inflammatory effect, if it's such a pure diuretic, maybe you could change it. You could challenge that paradigm by giving a different diuretic.
Got a couple more questions. A comment from Dr. Betsy Charles. She says, really great webinar, although as a radiology resident, this information doesn't make thoracic radiograph interpretation any easier. Thanks, she learned a lot. I'm going to give you one more, Bob, and then I'll let you address those. And then Dr. Fisher says, points all well taken. Thank you very much. And it looks like that's about it for our questions. And anybody else have anything they'd like to add or ask? Feel free. Otherwise, we'll wrap this up and let you guys all get back to your busy days. In the follow-up email, and Dr. Fisher, I'll grab your question in just 1 second. In the follow-up email, I will also include Dr. O'Brien's email address if you had any other specific things that you wanted to ask him about or address. I'm sure he would be more than happy to respond to you. And just as another reminder, I will be sending out your CE certificates within the next 5 to 7 days. I'll include some extra information and Dr. O'Brien's email address for everybody. So thanks, guys, for your time and for attending. We look forward to hopefully having you on some future webinars. Have a great afternoon. Bye.